Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello and welcome to a very informative discussion on COVID-19 pandemic. I'm Leanna McGuire, your host for this Elite Learning podcast, and our guest is Dr. Daniel Griffin. Dr. Griffin is a physician scientist, board certified in internal medicine and infectious disease, with expertise in global health, tropical medicine, parasitology, and virology, including SARS-CoV-2, also known as COVID-19. Welcome, Dr. Griffin.
Oh, thank you so much.
I have quite a few questions for you. This is an interesting topic we're always asking questions about. So COVID-19, we're all aware of what it is, having lived and survived 2020 and beyond. Have most of us been exposed at this point?
So we think so. The latest data suggests that over 90% of people have been infected. I know people are out there thinking, well, not me. And I'm one of those people who thinks not me. So there are a few people out there left out. We're going to have a big party at the end and get them infected. But it's estimated that 97% of people in the United States have had some form of immunity, either from prior infection or vaccine. And a lot of people have both. Majority of Americans actually probably have both.
Right. Interesting. And what is COVID-related mortality? Where do we stand with that?
It's interesting because it has changed over time, certainly, but not as great as I think we wish it had. So, early on, the case fatality rate was 2%. So what does that mean? Case fatality is if you have, a bunch of cases, let's say 1,000 people confirmed, they've got COVID-19, about 2% of them did not make it. That has dropped down to 1% or lower. So it has dropped. A lot of us thought it would drop lower, right? We talk about vaccines that should have dropped at 90%. We talked about effective therapies that should have dropped it at least, in half just by themselves. So there still is, unfortunately, a significant case fatality rate out there. We're still seeing 300-400 deaths a day, but we're not at 6,000. Oh my!
Right.
So yeah, just to give. We're celebrating at a number that we would have been horrified prior to this pandemic.
And those mortality rates, would that be predominantly unvaccinated, or are you seeing a mix of both?
So it's changed over time. What has happened is, over 90% of the highest risk individuals, right, have some form of immunity. So we're now shifting to the point where we're starting to see the majority of deaths actually are in people who are vaccinated. But a couple of sort of caveats here, 90% of the deaths are in folks over the age of 65. Among those, it's predominantly people that have multiple medical problems. The other side, though, to point out is 10% of those deaths are people under 65, right?
Wow.
So we've seen, hundreds of children succumb to this virus, most of those deaths during Omicron. So we still continue to take this seriously. It's still a significant threat. We're still seeing lots of people dying. Vaccines do a bunch, but as we'll talk a little bit later, that's not where it stops. You want to just not rely on vaccines alone, but you want to add on to that.
Okay, great. Now, I'd like to talk to you about testing as well, because we keep hearing, I keep hearing, I'm sure others have as well, where I tested negative, but I'm sure I had it. Are home tests reliable?
So they're reliable to a degree.
Okay.
And the to degree depends, when used properly. So one thing is nothing's 100%. And the rapid tests are not 100%. So that's just important to start with. The other is timing matters and repetition matters. So, if you're just starting to get symptoms, and we don't know if this is because of prior immunity, we don't know if this is because of the different variants, but some people will be test negative during that first day and not start to test positive until the next day. And some folks, actually, it's the following day. So most of the home tests now have a recommendation in there to do a test the next day. So not that first day of symptoms, but the second day. And if that's negative, to actually go on and get another test. Still higher sensitivity with those PCR tests. And if you're an individual who's at high risk, because timing matters, you may not just stop with those rapid home tests. You may want to actually look at getting a second test to confirm.
Got it. And while you're waiting a day or two to test, I'm assuming isolation would be a good idea if you're having those
Yeah, I mean,
symptoms.
if you might have COVID and you're waiting to find out, you really don't want to be out there spreading it to others.
Right. Okay, great. Now, what about ventilation? Does ventilation make a difference? I've heard that it does. Do you have good ventilation in your home, or is that just a
Yeah, so
wives'
it
tale?
really does.
Okay.
Yeah, ventilation is huge, and I really think we haven't used the resources, we haven't used the tools. This is a dilutional thing. When you're within 3 to 6 feet, okay, you're within sort of the highest risk zone. But once you get outside that zone, if you're in a poorly ventilated space and you're there long enough, if a person with COVID is there long enough, we're still seeing infections. So ventilation is important. I mean, the best ventilation as you're outside in the great outdoors with a nice airflow. But if you're indoors, particularly those suburban homes, those apartments, cracking the windows. If you have, AC or heat, leave the fan on. Don't turn it to auto and have it off and on, particularly when you have folks in the house. So no, ventilation has been shown to significantly reduce the risks.
Interesting. That brings up another question is we often see people, I hear people criticizing those who are out walking their dog with a mask on. Do you feel that that's a necessary precaution when outside?
So one thing we've learned, and I think this, scaring the wrong people issue is that, if you're out and you're by yourself and you're walking the dog, your risk of getting COVID is pretty much nil. There are crazy viruses that can blow across the English Channel. SARS-CoV-2 is not one of those. So no, if you're out and you're walking your dog, if you are driving by yourself in your car, you certainly don't need an N95 on. I'm not sure there's much utility at all to masking in those situations. So,
Okay.
I think we should start following the science. Take a deep breath, and if you're out walking the dog, enjoy that.
Yeah, there you go. And if you're criticizing someone for walking their dog with a mask on, stop. There's
Well,
another
I think
thing.
I think that's the other. Yeah, let's not mask shame people.
Yes, exactly.
For a lot of us, this has been traumatic, particularly if it's a person with immunocompromise. This is still continues to be scary, and now maybe it's a little bit scarier now that we're losing our monoclonals. So if someone is wearing a mask and they're comfortable doing that, I have to say, when I was in Japan, a lot of the young ladies would wear masks just because they didn't want to do their face. They would tell me,
Yeah.
so maybe that's what's going on.
Did save a lot on lipstick. There is that. We'll talk about the monoclonals in a little bit. That's an interesting discussion. Talking about masks, when they started lifting the mask mandate, were there increased cases? What was the result of that in your findings?
Yeah, so that was actually one of the areas where we got I'll say good data. There was a state where it was lifted incrementally. So certain schools they continued to just keep the masks. Other schools they would reduce the mask use, basically say no more mandates. And we clearly saw an increase in cases in the schools where the masks were taken off. And we'll try to put this in a little bit of perspective. So, masks, particularly if you have COVID, whether you're asymptomatic or symptomatic and you're wearing the mask, there's a great benefit for everyone else for that source control. Um, Also, there is some benefit to wearing a mask yourself if you're in a setting where that other person has COVID. So what we saw in those schools was that the mask would come off, and then the schools where the mask would come off, you would see an increase in cases, and actually gave us sort of a count of how many cases were sort of associated with the lifting of those masks. But the other side is that we now have, and we'll keep discussing this, we now have highly effective vaccines.
Mhm.
We now have a population where 97% of the population has some form of immunity. And I don't want to forget about the immunocompromised who are in a tough situation at the moment. We have effective medications. We're also stopping using things that were harmful, right? I
Mm,
mean, I was looking at a paper today where early use of hydroxychloroquine may have actually resulted in more people dying.
wow.
Early use of steroids actually caused some people to not survive who would have survived if they had been left alone. So,
Wow.
vaccines, highly effective therapies, getting rid of things that are harmful. So, COVID is here to stay. So, part of the mass discussion is what are we going to be doing going forward? Which measures are more or less acceptable in these different contexts?
Should we be returning to masking?
I think on an individual level, I've never been a huge fan of mandates.
Sure.
I think it created a lot of tension.
Mm,
I usually on the side of education, explain people what the benefits and risks are, and mass went sort of back and forth. So if, as we discussed, you're a person who's a high risk individual, if you're going to the supermarket, and for you, getting any respiratory virus, including SARS-CoV-2, COVID-19, is going to be a major risk, then there's really no downside if you're comfortable with wearing a mask in the supermarket, wearing a mask in a crowded indoor setting. Recently, my daughters went to a Broadway show in New York City, and they wore masks. A very crowded, very dense, not necessarily the best ventilation. So there are the situations when it makes sense to wear a mask. But then the other side, we talked about someone out walking their dog. You really don't need to do that.
okay.
So I think it makes sense for people to understand the science and when it may or may not make sense.
So on a plane, for example.
So I do wear a plane. Do wear a mask on a plane, and the highest risk is in that getting onto the plane, right? So you're all crowded together. You're in the aisles. Once you're in your seat, it's the people around you. So lower risk. So if you're going to wear a mask, wear it the whole time. That's great. If you're only going to wear it part of the time, it's really the getting on the plane, getting off the plane that are the most important.
Got it. Excellent. So if you've been exposed and have tested positive, can you clarify for us how long you should isolate and why?
Yeah, so this has been a challenge and controversial, but I'm sort of amazed because we have a tremendous amount of data of science here, and we have pretty soon 3 years
Mm,
of science here. Forget about which variant, just in general. You are the most contagious during the first 5 days, right? So it starts a little bit before symptom onset, and it's really the 5 days from symptom onset that we see 90% of the transmission.
mm,
Not 100, but 85, 95, 90%.
okay.
During the 6 to 10 days, there is some degree of transmission. And that's when we talk about if you're going to go back to work, if you've got to, that's the wearing the mask, that's not eating in communal areas. So, really, the clock in most cases is the most reliable. The calendar is the most reliable. I know there's a lot of discussion about testing, and should I test and does that tell me? We try to correlate that with culture positivity and
Mm,
negativity. If it's day 9 and you get a positive antigen test, it's 50-50 that you're going to be able to culture any virus. And if you get a negative antigen test, it's also 50-50.
mm.
So, really, I don't encourage the testing as a way to find out. It's really the clock. But then again, if you're someone who's immunocompromised, if you're someone who had a really severe case of COVID, then there are some situations where we may see infectiousness beyond that 10 days.
Interesting. Okay. There's also been a lot of division on the topic, so let's talk vaccines. Uh, effectiveness, boosters, etc.
Yeah. So vaccines, first 2, 3 doses, really, I think that, very clear, compelling data. The data we were surprised, 90% reduction in people ending up in hospital, 90% reduction in severe disease. But then boosters, particularly the bivalent boosters this fall. And there were two sides to this. One was, are the new boosters any better than the old boosters? And that was a bit of a controversy. Slightly higher antibody levels. What does that mean? We're not really sure. Targeting BA4, BA5, which are really not around, maybe 10% of the. So targeting a variant that's already gone, that was sort of what a lot of people were saying. You're going to be chasing your tail. By the time we hit December, January, those variants won't even be around. So what are you doing?
Mm,
So that was one side. The other was what's the real world data now that we have it on how well do those boosters work? And it's just listening to the MMWR report. They have a podcast today. They're saying significant reduction. Well, what is that significant reduction? It's about 20%.
mm.
So really getting a little bit more with the boosters, still encouraging those boosters, but not saying everyone has to get them. If you're a high risk individual and you can reduce your risk by 20%, then boy, that's certainly worth doing.
Yeah,
But if your risk of severe disease is already zero, a 20% reduction in zero is still zero. So
good point. Are we looking at a future of annual boosters? Is this going to be like a flu shot, or is it going to be tailored to the current variant at the time?
So I think we're going to learn in the next few months here, and I think the next few months are going to be critical. So there's two ideas on how the vaccines are working. So one is the being antibody B cell dependent,
Hmm.
and we have these new variants now that are basically resistant to the vaccine induced and the monoclonal antibodies. So is the vaccine protection against severe disease really T cell based? And the T cell base is much more durable, much more reliable, much harder to get through. So in the next couple months, we're going to see, do we need to keep boosting those antibodies? Or once we get that memory T cell, are we going to have the protection we want? So
Mm,
a lot of people have decided they can tell the future. I don't think we quite have the science yet. So science will tell us.
interesting. Now, let's talk about with the actual phases of infection. There's hypoxic and non-hypoxic, et cetera. Can you go through that for us and talk about those?
Sure, and I think this is really important. The
Hmm.
timing of COVID-19 and understanding the timing is important as an individual, what to watch out for, but it's also really important when it comes to treatment. So the first week is this viral replication, non-hypoxic phase. It's when you feel crummy. I've got a fever. I've got a headache. Everything hurts. You feel sick, like you feel like you've got a virus, and really the only way to tell whether it's COVID or not is to do a test. Um, that's the time when a lot of our frontline antivirals are effective. So that would be Paxlovid as our number one choice. Then, in some situations, we have access to IV remdesivir during that time. We've lost our monoclonals. We still, in some cases, have molnupiravir. Um, During that first week, when you've been vaccinated, maybe you've had prior infection, when your immune system is trying to fight off the virus, this is not the time to turn it off with steroids. And we've seen that if you do that, if you treat a viral infection, SARS-CoV-2, COVID-19 with steroids, you actually increase your chance, or if you're the provider, you're increasing that patient's chance of progressing to week two when they get this early inflammatory hypoxic phase.
Okay.
So week two, starting, about day 8, 9, 10. So that second week, this is when we see that cytokine storm, that pulmonary phase. When the virus has started to go down, there still is some detectable virus, particularly with PCR. And this is when you start having, in some cases, trouble breathing. This is when your oxygen saturations might drop below 90, 94%. You've missed your window of opportunity for Paxlovid. There might still be some benefit for remdesivir if you're still within the early part of that second week. This is when we start looking at immune modulation with things like steroids if that drops below 94%. So really, timing is really critical. And I tell a lot of patients, hey, it's first week. Let's say we treated them. It's week two when I say get one of those pulse oximeters, start checking your oxygen levels. I need you to call me if that drops below that magic 94%, because we may want to step in.
Is Paxlovid appropriate for everyone in that early phase?
So no, it isn't. It isn't. The science would not say it's appropriate for everyone. It was studied to do what? Prevent progression to severe disease. So this gets back to this. Well, if your risk of progression to disease is zero, well, what are we
Right,
doing with
right.
Paxlovid?
Yeah.
So
Okay.
just sort of to go through. So if you're a high risk individual, maybe you're over the age of 65, maybe you're carrying too much weight. Say that nicely. Maybe you've got multiple medical problems. There's a list of different factors that might put someone at a non-zero risk of progressing, ending up in the hospital. So Paxlovid can reduce that. Early studies, pretty impressive, 88, 89% in the unvaccinated cohort they looked at. The real world data, we're getting about a 50% reduction, a little more than a 50% reduction in ending up in hospital, ending up in that severe disease group. The other thing we don't know, and I think it's important to say, is does it prevent long COVID, which is another
Mm.
severe disease manifestation? Some early data encouraging, suggestive, but we don't know. So the current indication, the current recommendation is not for everyone. It's for people at risk of progression.
Same case with remdesivir, I'm assuming.
Yeah, it's the same. So our therapies are Paxlovid or remdesivir or molnupiravir, not for everyone. It's for individuals who have a risk of progression, and we're hoping to reduce that. If you're, 25, if you're healthy, if you're ideal weight, if you're active, no medical problems, it's not clear that we're going to do anything helpful.
Okay. And you mentioned steroids as something that should be avoided in that early phase. Anything else that we should avoid?
Yeah, I mean, the first week, remember, this is a virus. So whenever I read these articles about it, we're having antibiotic shortages because of all the respiratory viruses. I'm sort of shocked. What are people doing treating viruses with antibacterial agents? Yeah, there's no role. We've looked at those Z packs, which
Mm,
people say, oh, it's anti-inflammatory. No, it is not. And if it was, that would be a bad thing. So no antibiotics during that first week. A lot of other things out there that hopefully have been dispelled. Won't give them any air, but there's a lot of unproven therapies out there that are still being encouraged, but the science does not support them. So let's not do things that are harmful, things that are unproven. Let's not lose the opportunity to do things that can make a difference.
excellent. So variants. We've lived through a few of them now, including Omicron. In fact, we recently heard says that they're keeping their eye on a variant called XBB right now. You can probably talk more about that. What do we need to know about current and future variants?
Yeah. So XBB, there's a good and bad side to XBB. Mostly a bad side. We'll start with the bad side. So the bad side to the newest variants that we're seeing is they have actually been really doing well, out competing, fitness wise, the other variants. Starting to spread in India, starting to spread in parts of Asia like Singapore. We're actually already seeing them starting to spread here in the United States. Particularly the XBB and the XBB group are resistant to neutralization by all of our monoclonals. They also tend to be highly resistant to sera from people that were previously infected and people that were vaccinated and even people that had both.
Wow.
So this is really antibody evasive. And this is going to, well, what's the good side to this, Dr.
Right.
Griffin? How can there be any good side? So the only potential good side that I see is this is going to answer that question. Do we need to keep boosting? Do we need to keep relying on antibodies? How much can our T cells do to protect us? So that's going to actually inform us from a science point of view. If it turns out we really need those antibodies, well, then we've got to update our vaccines. We've got to update our neutralizing monoclonal antibody treatments.
When you say that we need to update them, that's not an overnight process, correct?
No, it's really not. It takes, well, but it does. It takes weeks, not months
Well, that's good.
necessarily. Um,
And then they have to get passed, though, at certain point, FDA, that
Yeah, so the,
process.
the the regulatory part might take longer than the actual
Sure.
producing them, right? We have great systems in place at a lot of labs where they can do these pseudo virus neutralization, and also a number of these high BSL-3 level labs where they can do real virus neutralization, test the antibodies, see if they work. Because all the modeling you do, you really need to actually test and see if they work. Once you show that they work, once you show they can neutralize, then wonderful hurdles of getting through our regulatory agencies to hopefully get them out to people.
Yeah, I mean, it's fascinating. There's actually a fair number of cases, aren't there, in the US?
We are seeing lots and lots of cases, yeah, and I think the one hard number that is easy to put your finger on is
Yeah,
deaths, right?
yeah.
We're looking about 400 deaths a day. We're looking at almost 3,000 deaths a week. That's just enormous. Hospitalization rates are going up. So
S
yeah, it's there's a lot of virus out there right
Yeah,
now.
and those 3,000 a week, are they specific to XBB, or is this, any of the
No, at
previous
this
variants?
yeah, at this yeah, at this point, XBB is just coming on the
Okay,
scene in the United States. It's still less than 10%. So we'll be seeing that, 20%, 40%. That's gonna be probably by January, really moving it as a dominant.
okay. Um, so some people think they can see into the future.
Yogi Bear says that's the hardest thing to look into.
Gotta love that guy. Yeah, so do you think that potentially we're looking at another, closing borders, isolation, shutdown potential? Not to, I'm not a fan of anticipating or building fear, but could that be a reality based on the new variants and the way they attack?
Yeah, I mean, from the science standpoint, from here we are. It's the time of year when a lot of people are together
Hmm.
indoors. I would be surprised if we did not see an increased number in cases, an increased number in deaths. I do not think we're going to get back up to 6,000. I actually am one of the folks in the school of I think our T cells are actually going to come to save us all. Uh, I also don't know if there's much of a political will, or even if it really ever made a lot of sense. A lot of these border closures. So hopefully, realizing that it's not helpful, it's harmful. Let's do things that we've learned to make a difference. So yeah, I mean, I think as we get into this, a lot of things we've learned. So we've learned about the importance of vaccines and having immunity. I think a lot of people have gotten it either way, voluntarily with a needle or by breathing. The other is we now have understanding about ventilation. Outdoors is safer than indoors. People are a little bit more intolerant to folks showing up for an event, coughing and sneezing and obviously sick.
Yes.
We do have testing, so those that want to make a difference can actually prevent themselves from showing up during that asymptomatic period. I think we've learned a lot. So, yes, COVID is here to stay. It's going to continue to impact us, but we're not where we were, in the early days of 2020.
Thankfully, thankfully. This is a fascinating field. You must, I mean, as dreadful as a lot of it's been, there must be just a lot of just so much education on a regular basis and information that's coming in to keep track of from your perspective. It's got to be exciting on one level. I hate to say that as you know what I mean, but it's an interesting time
Yeah.
for your practice.
No, yeah, it continues to be a fascinating time for infectious disease. And my hope is really that we continue and we've learned a tremendous amount. My hope is we continue to learn a tremendous amount, not just about COVID, but also learning about other respiratory pathogens, learning about RSV, learning about flu, learning about, all these rhino
Hmm.
enteroviruses that were circulating. Also learning about all these post-infectious syndromes, right, that people have been troubled with.
Sure.
I think we're getting better insights into the chronic fatigue, MECFS, into people with post Lyme.
Hmm.
And while a lot of people are struggling with post COVID conditions, we're learning more and more about what's going on. So I am hoping, I'm enjoying that aspect, just the tremendous amount of knowledge, and the idea that that's going to lead to people benefiting from all this knowledge.
It's um it's been an interesting time when I think back on the naivete of most people over the last several decades. It's really brought forward the fact that we are vulnerable to such a degree. Do you see a future where other pandemics may raise their ugly heads other than COVID at some point?
Yeah, I mean, to be
Right.
realistic, right? We were anticipating a
Okay.
pandemic. We anticipated another pandemic. It's kind of a question for human, how often do these happen, and what is the agent that drives it, right? We were expecting and preparing for a flu pandemic, and we got a
Mm,
coronavirus pandemic. And getting a coronavirus pandemic does in no way move the influenza pandemic possibility off the
sure.
table. We need more effective therapies for flu. Um, we probably need home testing for flu, right? So we can use a lot of what we learned here. The advantages, right, with flu, if there is a flu pandemic, or should I say, when there's a flu
Mm,
pandemic, is that most of the transmission is when symptomatic. So that's going to help us to some degree. We don't have as much asymptomatic transmission. um, yeah, so most of us are expecting, and I don't think sky falling, just
right.
sort of the deep breath of yes, this is our reality. We live in a world. None of us are immortal. There are viruses out there, and hopefully we've learned a lot. So we don't do things like close borders when that's not useful. Do a lot of stuff that's theater. Really, what is the science? What can we do to keep ourselves safe?
Right. And just the pure mobility of mankind now in travel, it's gonna move around.
Yeah, no, I mean, I think that's the challenge. Within 24 hours, you can get from really any
Yeah,
spot on the planet to another. So, yeah, and that's not going to change. And the other, and this is just a reality, human beings like being around other
they
human
do.
beings.
They just do. And yeah, it was tough for a couple of years when we couldn't be. It was a real challenge for a lot of folks. Okay, well, Dr. Griffin, knowledge is power, and we as health professionals are more than grateful for your expertise today. Thank you for taking the time to inform and educate us. and our listeners. And thank you for listening today. We've talked about the significance of timing for testing, the impacts of ventilation and masking, isolation and vaccines, and a little bit about variants. So we would like to continue the conversation in episode 2. Please join us for the rest of our podcast in the next episode. This is Leanna McGuire for Elite Learning by Colibri Healthcare.
This podcast featured content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.